go on to the next topic. Dr. Vinod Kumar will be speaking on pneumatic retinopexy for RHEGMATOGENOUS retinal detachment, timing, when to do, when not to do, and follow-up.
Good morning, everyone. So today I will be speaking about pneumatic retinopexy, that my experience in the last 1 year. So although it was discussed back way before 35 years as a two-step procedure by Hilton and Gizzard, it actually involves injecting a gas bubble inside the vitreous cavity that is coupled with must laser or cryotherapy. Because of the advancement in pars plana vitrectomy or better buckling techniques with chandeliers, assisted by buckling, and also this pneumatic retinopexy lost its charm. The indications for pneumatic retinopexy that was discussed 30 years back were the breaks which were there in the superior part of the retina, that is anywhere between 8 to 4 o'clock meridian, and the breaks should be within 1 hour clock meridian. And if there are any breaks in the inferior retina, the retina should be attached, or if there are any lattice degeneration or peripheral degeneration, they are allowed. So the exclusion criteria is the inferior break in the detached retina, significant media opacity, or if there is a development of PVR, and if the patient is not able to maintain his position, mental incapacity, or the patient, younger patients, or one-eyed patients. So with the advent of better imaging techniques and better scleral depression examination, the criteria can be expanded to more clock hour breaks, or sometimes the number of breaks can be more than one, and if the breaks are more than one, the multiple change in position can be done to treat the retina. So the greatest success of pneumatic retinopexy is appropriate case selection. So thorough scleral depression examination is must to look for all breaks, even though they are in detached or attached retina, and also look for all peripheral degenerations which are likely to open up post gas injection. With the advent of optos or ultra-wide imaging, this scleral depression work has been partially replaced, but scleral depressive examination is very must. So the beauty of this procedure is can be done on the same day, but things to be considered about the positioning, especially that if the patient is of old age or cervical issues or back or spine issues, they should be counseled accordingly. I usually perform inside operation theatre, and indirect laser or laser through the slit lamp delivery is must within 24 to 48 hours or as early as possible. Cryotherapy can also be done. All the aseptic precautions as we take for intravitreal injection, and AC tap so that the eye is made soft. Take fluid as much as possible. For case of pseudophakia, we can go to the needle can be taken up to the center of the pupil and remove as much as fluid, as much of AC tap as possible, and inject the gas at around 3.5 for pseudophakia and 4 mm for phakics, especially away from the bullous component, and try to be in superior nasal or superior temporal component. So what is the appropriate gas bubble we should inject? There is no such criteria, but ideally it should be around 3.3 to 0.4 ml more than the AC tap, or it can be higher in case of myopes or slightly lower in case of hypermetropes. SF6 can be injected up to 0.5 or 0.6, C3F8 can be injected up to 0.3. SF6 is a better option because it goes away within 2 to 3 weeks, whereas C3F8 stays for more than 35 to 40 days. So the tableau column shows this is the arc of contact for non-human eyes. Even for the human eyes, if you inject 0.3 to 0.4 ml, you can give an arc of contact of 45 to 50 degrees also. So once we go inside the vitreous cavity perpendicularly toward the center of the eye, gradually withdraw the needle and inject the gas bubble very slowly, and once you take out the needle, put a small cotton tip bulb so that the air or vitreous should be, it will not come out. So post injection, if the detachment is macular on, prone position should be given for at least 6 hours, maybe more than that, so that the macula gets settled first. If it is done for macular on detachment, earlier we can ask the patient to lie in the position of the break for initial 2 to 3 hours of prone position. If it is not on the table, if not possible immediately on the table, patient can be shifted to the bed, or it can be stream lower maneuver is the technique where patient is made to lie supine for some hours and gradually with 30-degree increase in the elevation of the head, so that the bubble directly tamponates the break. So laser is a must, as I was telling. So routine post-op medications, and always avoid, tell the patient to avoid supine position to avoid cataract or pupillary block. So this is my short case series where almost 12 patients were fit for this PNR. After convincing, 8 patients got ready. And of all these, 6 patients are doing well. 2 patients developed reed detachment. One because of macular hole detachment, other developed a new hole. So this is one of my case where the patient presented with a temporal hole. You can see 2 holes are, one larger and a small hole. So identifying a small hole is also makes a big difference here. So there is a detachment coming up to the macula. So this was the day 1 picture. I injected a gas bubble and did a laser on the same day, and the patient is doing well, 6/6 vision. So this is another patient where the macula is also off, completely off. So patient was injected. There was still media, but I could do the laser in the slit lamp and cover the superior break, and patient did well. So what I haven't tried is the breaks more than 6 claw apart, and I haven't tried rebubbling in these cases, and I also haven't tried cryo. But these are all discussed, and they are people are doing this. So the cases where PR has particular advantage is phakic eye, especially young patients, macular cases, bullous already where you have already identified the break, and it is a very less expensive procedure. It can, but we do under operation theatre. It can be done in the OPD also. The more advantage with the pneumatic retinopexy is better physiological attachment and lesser chances of metamorphopsia. I can see this is the case of post-VR vitrectomy detachment. You can see the inferior part of the retina is getting displaced, and patient will have metamorphopsia with these kind of attachments. Pneumatic retinopexy has better advantage. So disadvantage is smaller bubbles, fish egg formation. So conclusion, pneumatic retinopexy has a better results, minimal morbidity, and even if PR fails, vitrectomy is also the option is still open.
Yeah, very nice presentation. Dr. Vinod Kumar, thank you.